Quick disclaimer. The Airway Circle Radio podcast has been produced for entertainment, educational, and informational purposes only. All of the content, views, and opinions shared by our hosts and guests should not be a substitute for medical advice. Please consult your healthcare professional for any medical questions. Welcome to the Airway Answers Podcast, expanding your breadth of knowledge. Our wonderful host is Nicole Goldfarb. Nicole is a speech-language pathologist, certified orofacial myologist, and an international speaker. Nicole is the owner of San Diego Center for Speech Therapy and Myofunctional Therapy. She has a special passion and interest in sleep-disordered breathing and diagnosing restricted frenums as they relate to myofunctional disorders. In the Airway Answers podcast, Nicole will be interviewing specialists in the airway realm in order to help our listeners learn and understand all of the components to airway-focused treatment. You can help us by sharing this podcast episode with your friends and colleagues. Enjoy the show.
Hello, everybody, and welcome to Airway Answers, expanding your breadth of knowledge. And we have Dr. Jeremy Manuele. Am I saying it correctly? Manuele?
You probably say it better than me. So, it's Italian, it's Emanuele. And then now we just say Manuele, but, I respond.
I keep saying Manuele. I love the Italian.
There you go.
But your patients refer to you as Dr. J. Is that correct?
A little easier. Yeah. A little shorter. Yeah, the first name's Jeremy. So, that keeps it simple.
And Dr. Manuele is a dedicated orthodontist from Las Vegas, Nevada. And he began his orthodontic journey at UNLV School of Dental Medicine and completed a 2-year orthodontics residency at Louisiana State University Health Sciences Center. And he also continues to share his expertise as a part-time orthodontic instructor at the UNLV School of Dental Medicine. And Dr. Manuele has a private practice, orthodontic practice in Las Vegas currently. And this part of your bio I found also very interesting. Service is deep rooted in Dr. J's story, Dr. Manuele's story. Inspired by family tradition, he joined the Army National Guard at age 17, dedicating 21 and a half years of service to his country, including an 18-month field artillery deployment in Iraq in 2005 to 2006. His military journey culminated in retirement as a major from a local medical unit in 2022. Amazing. And thank you for your service. That's amazing information. In his commitment to the orthodontic profession, Dr. J recently created the MARPE 360 online course. And that's one of the things we're going to talk a bunch about today. This course is a comprehensive continuing education course for dentists focused on airway health and non-surgical adult and teen skeletal expansion. Driven by a genuine passion for teaching, his focus continues to be on the professional growth of the orthodontic community as a whole. So welcome, Dr. J.
Thank you. And thank you so much for having me. I'm truly honored to be here.
This is going to be fun. I am so excited because I have taken part of the course and I'm not finished. And I said, I need to get Dr. J on here right away, even before I'm finished the course, because this course is so good. MARPE 360 course. So do you want to talk a little bit about your background, your experience, and then what the course is?
Sure. Yeah, it's interesting because, if you would have told me, about 10 years ago when I was in residency that I would be practicing orthodontics the way that I am, I wouldn't have believed you. Like I would have said, no, you're crazy. There's no possible way. My experience with, airway orthodontics or even early treatment was very limited in residency. And that's the same story as many of us orthodontists. It's just not something that's very prevalent. The traditional, last 20, 30 years of thinking has always been, well, if you can do everything in phase 2, just do it in one phase, don't treat them early. And so I had professors that would, pull baby teeth, and that was their solution to crowding. They'd pull some baby teeth, and then they'd pull more baby teeth, and 2 teeth needed to come in, so they'd pull 4 baby teeth, and eventually just set them up for serial extraction. And the idea was like, oh, great, their teeth are straight, wonderful. Our profession as a whole has been so focused on straightening teeth, no matter what. If you can get the teeth straight, great, do it. It just never resonated with me. It never made sense to me to, set kids up for serial extraction. I'm like, why is this problem happening in the first place? Well, they probably don't have room for their teeth in their jaws. And really, it's the increased prevalence of 3D imaging that's really allowed what I feel like is leaps and bounds of understanding and treating these cases and making sure that the underlying anatomy and the underlying problems are corrected. And so, my journey out of residency, I joined a practice who was fairly pro expansion. They did quite a bit of expansion anyway, and this is before we had 3D imaging. And as we've continued to learn and more of the airway physiology science has come out and more research has come out as far as what we can do in changing the underlying jaw structures in the bones, I just kept kind of going down that road. It was never an endpoint, that I was seeking out or that I necessarily wanted. It was just, once you see airway, you can't unsee it. I've heard that said before, and it's so true. And so, you start to learn things and you start to see and understand the changes that are happening with these patients. And, as soon as I realized kind of how important this was, my next goal was to be able to get the information in the best and easiest way possible to as many people as possible. Because at the end of the day, the only way that this is going to progress and the fastest way that it is going to be able to move forward is if more people are involved. And so, my journey on this road was very laborious, many in-person courses, which were amazing. Like, I'm so grateful for all of the educators out there in this space, yourself included. I mean, that go out of their way to provide good education for people. But at the same time, with this specifically MARPEs, MSEs, the education was very, very difficult to find. And so I wanted to put some good research-based quality education online where people can go and they can watch it on their own time. And then, give them the overview. And then once they have the overview, well, then they can seek out, whatever else they want. But at least they have a clear picture of what's going on in this world and where we are currently with the research and a good base to start from. And so that was the goal with the course.
Yeah. And so far, I'm about halfway through. But what I really appreciate about the course is it's not just like jump into MARPE, here's how you do it. But it's a whole background about what is airway, tongue ties, how does this all relate? You put in such a comprehensive nature to this course. How do you foresee the course being? Is it like an introductory course before taking other courses, or how does it fit into all the other? And there's only, I think, a select few MARPE type courses out there anyways, but what are your thoughts?
Yeah, so here's how I see it fitting in. So, I structured the course in a way that it is comprehensive, because at the end of the day, I think the biggest resistance we have is from people who don't understand the big picture of why we're doing what we're doing. And so they see one case that comes into their office and they don't understand what's happening or maybe where the other doc was coming from. And so, then they can just, poke holes in whatever they're seeing, right? And so we have all this resistance in our profession as a whole to airway treatments, to MARPEs, MSEs, things like that, because people don't understand it thoroughly. And so, in the beginning, I said, okay, here's the framework. Here's the history. Like, this is what, I started from a place of where all orthodontists start, basically, which is what we learned in residency. And from there, that's when I expound into, well, okay, since we left residency and other things that are, happening since then, this is how this all fits in. And this is why this is important. So I felt like that framework was critical in the beginning. Now, whether or not somebody takes my course and then starts doing MARPEs or MSEs, certainly all the information is in there. And some people are very good at learning from things like, online recordings and slide, shows and PowerPoints. And there may be some people that take the course and feel comfortable doing treatment, but that wasn't the main goal. The main goal was to help people understand what they need to know, like give them the overall view. So if they're going through this and they're like, whoa, like this is pretty foreign, or like, well, I didn't know that could happen. That's going to set the foundation for, do I want to do this? Is it something that I want to get involved in? And so I wanted them to have an understanding of the big picture to make sure that it is something. Because when I started doing these, like I did not, that's why I named the course that, what I wish I knew before my first MSE. There were so many things I didn't know about skeletal expansion. And had I known those things going into it, I would have gone into it a lot differently. Personally, I probably would have taken other courses before I started doing some of the treatments that I did. And so the goal is to, kind of help curb that learning curve a little bit and, help people not get into trouble, help them know what they don't know so that they can then decide what they do need to know and they can seek out those courses appropriately. So I don't view this at all as a standalone, this is the only course you're ever going to need to take. For that matter, I don't think any of the courses out there are like that because you only ever get one person's perspective. I think the perspective I provide is good. It's research-based. It's fairly thorough. But it's not the only perspective. I mean, and there's some other, there's many other great educators out there in this space who, I would highly encourage you to get as many perspectives as possible, the more involved you get with these treatments.
Yeah. And your MARPE 360 course, like I said, is so comprehensive, but it's also so detailed. So somebody could go right to installing MARPE appliances. You go through every detail of what comes in the kit when you purchase it. What are the different sizes of tabs? I mean, every specific detail, how to install, video, everything. It's really great. And I feel like even as me being just a myofunctional therapist, a speech pathologist, I have a lot of patients that I refer to MARPE providers, and it's important for me to know all of these details. So as speech therapists, myofunctional therapists, I think your course is great for them also, who wouldn't obviously be installing appliances, but just to know all of the details of what our patients are going through, what the orthodontist does in the whole process. I just thought it was really great. And no course, I believe, is standalone ever, because in any field, if you think you can stop learning by taking one course and you're good, that's not good, right? Myofunctional therapy, we must take many courses. It's never like take this course and you're done and you're good to go. So I think that's wonderful how you present it. And can you tell me about other MARPE courses you've taken? Because it seems like you've learned from tops as well.
Absolutely. Yeah. So I started my journey way back. I took Dr. Juan Moon's course. Like in hindsight, like I love Dr. Moon. I love what he's done for our profession. I mean, honestly, I don't think any of us would be doing the level of MARPEs that we're doing if he didn't, design the MSE and really popularize it, right? I think his intent was to take something that's complicated and market it in a way that it's a little bit easier to digest. And I think he was very successful with that. That being said, there was a lot I didn't know because most of my initial knowledge was based on one specific type of appliance. And so, I loved his course. I thought it was very good. I thought it was very well organized. I didn't feel like it was necessarily complete as far as MARPE expansion in general, but he's not promoting it as such. He's basically promoting his course as teaching you how to use the MSE. So I thought that was good. But after I took his course and started doing some MSEs, then I realized, okay, well, there's definitely some things here that aren't like I thought or that I need to learn more about. So I took Dr. Ting's course. I took Dr. Lipskin's course. Anytime I was at the AAO or other meetings where I could hear like Becca Bacow, Audrey Yoon, and all these speakers speak, I mean, I would go in and I would listen as much as I could. I learned a lot about complications from Audrey specifically. I mean, and Mariana, they're both like very, very great at showing all the things that can go wrong. And again, I don't know if you got to that portion in my course as well, but yeah, there's a lot that can go wrong. You want to know these things before you get involved and discover it for yourself. Dr. Ting's and Dr. Lipkin courses, I loved both of them, both in-person courses, both very comprehensive. They have a lot of similarities, but also a lot of important differences in the way that they do things, both very successful in their treatment approaches. And so I mean, I would highly recommend any of those.
Yeah, no, that's great. And you had a lot of mentors, you said, and you show pictures of all these people. I remember Juan Moon. Do you want to name some of the other people?
Yeah, let me see. Yeah. So Jeff Rouse. So Jeff Rouse, he runs the Spirit Group. And so he has an airway prosthodontist course. And so that was really fundamental in understanding the physiology. So part 2 of my course is basically my attempt at a summary. I mean, he has a book 300 pages long that he gives you when you attend his course. He presents, even more research than I could ever present in 1 hour. Part 2 of my course was to try and condense the physiology and the learning, the Stanford research, everything into a concise thing. But most of that came from Jeff Rouse. We talked about that part 2.
Sorry to interrupt, but I think in part 2 you also talk about like Excite OSA, the like e-stim unit for the tongue, mouth taping, nasal dilators, all different types of expansion. So that's what I mean is like, wow, this is really great information beyond just installing a MARPE. So that's great. I just had to put that out there because I haven't seen other people talk about all those details.
Well, here's the thing. I mean, the more you get involved with patients who need airway treatment and and I'm not even say airway treatment, the more patients you get involved that have sleep disorder breathing, right? The more you have to learn about sleep disorder breathing. And so when you network with ENTs, when you're networking with pediatric pulmonologists, when you're networking with sleep physicians, you start to be exposed and to learn new things. And it's like, okay, well, this is great knowledge to have. So, I mean, like, there's probably a ton of things I still don't know about. I mean, I just tried to share as much as I've come in contact with in the patients I've treated and with the people I've networked with, again, try to get it all out there. I mean, the Excite OSA thing, I mean, I learned about that last year for the first time. But again, it makes sense, right? As myofunctional therapy, it probably makes even more sense to you, right? Because you've seen it just through the exercises that you do. For some people, something like Excite and, kind of a TENS unit for the tongue, that might work. better. And there's some research behind it. And so it's important to know about these things for sure.
In fact, my husband just ordered one today. So we're going to see how that goes as a supplement to myofunctional therapy, because it, obviously wouldn't replace. But yeah, no, it's really interesting to have all of the different parts and put all the pieces together. So you had Jeff Rouse was a mentor for you, and who else?
Yes. So we talked about Dr. Lipkin, Dr. Ting. Lou Shimura, he runs a great airway, or I don't know if he does anymore, but at the time he ran an airway course with Henry Schein's group, and they did a phenomenal job of breaking down sleep disorder breathing in general. Sean Carlson and JC Quintero, they taught me a lot about 3D imaging in general, both airway volumes, but also just understanding 3D imaging, and the 3D superimpositions that you see in the course were derived from the knowledge I gained from them and their understanding of how 3D imaging works and how you can use it to understand what's happening with your cases, which in my opinion will become the standard dialogue for these types of cases to compare all types of cases. Because if you have a 3D superimposition, you can see exactly what's really, really happening. And so they were instrumental in that. Todd Shayer, he is a prosthodontist. He teaches with Marianne Evans. He was very, very helpful in the technicalities of the piezotome procedure, things to watch out for, also complications. We talked about Audrey Yoon and Becca Backout, Diane Barr. So she actually lives in Las Vegas. So we've worked on some cases together, and she's helped me understand a lot more about the babies and their growth and development and how the myofunctional craniosacral and how all that world fits into the stuff that we do as orthodontists, which was, very, very eye-opening. Sarah Hornsby, she was at a course with Dan Hansen and Donnie, I'm going to mess up his last name, Mandrara. They do a great course on myofunctional therapy, which I took a number of years ago. And that really opened my eyes to how successful myofunctional therapy can be and how important systems are within a myofunctional therapy practice, and how, myofunctional therapy is not apples to apples, right? It really does depend on where you go and their systems, because compliance is so important. So they help me to understand, how creating good systems can increase compliance and success rates for things like myofunctional therapy. Mike Gunson is a surgeon. He lectures a lot with Becca Backow, but understanding the surgical side of things is when MARPE or MSE is limited was super important. Patrick McCowan, he wrote the books Breath and also, not Breath, I'm sorry. He wrote the books The Oxygen Advantage and also Close Your Mouth. So networking with him and understanding, breathing and nasal breathing specifically and nitric oxide and the benefits that happen there. Sharuf Zaghi, as I'm sure many of your constituents know him and know of him. So his wife was actually one of my pediatric dental residents. Early on, when she was in residency, we worked on a few projects together, but his understanding and the literature he puts out about tongue ties, and even in adults, was very, very eye-opening, and understanding how that ties into the big picture. And then the other ones I talked about are Glenn Krieger, Scott Fry, and David Alfie. So Glenn and Scott, they're both kind of big in the orthodontic world as far as, having influence and voice. And Glenn's very airway aware of the research and a very big proponent. Went on his webinar and have networked with him to help spread this message. And Scott Fry, I put him on there because it was his Facebook post that really led me to try my first MSE. So I don't know how involved he is with it currently. I haven't caught up with him lately. But yeah, he's a good guy, great orthodontist. And, he posted an MSE case a number of years ago. And that was kind of, after I saw his results, I'm like, okay, I got to look into this more. And then many of you probably know David Alfie. He's a great surgeon. He does network and teach with Todd Shayer as well. And he has, again, a great approach to the surgical side and understanding those things as you get deeper and deeper into it.
This just shows how well-rounded you are. The Renaissance man of the airway orthodontic person. You have so many different sort of mentors or people that courses you've taken. It's just really great to hear that. That's why I just love those airway-centered, airway-educated orthodontists, because you really are getting the whole big picture, and it just helps us all work together so much better because we know these issues are multifactorial. And I wanted to ask you, I think sometimes people are confused when they hear MSE and MARPE and what's the difference. Could you just explain that?
Sure. Yeah. Okay. So and it gets even more complicated. So you look at the white paper. So MARPE is kind of the most commonly accepted terminology for any type of an expander that has screws that go into the jaw. So if you remember that, like anything, if it's an expander and if it has screws that go into the jaw, it's a MARPE. Okay. So sometimes they call them MARMEs. All right. And the MARPE stands for mini implant assisted rapid palatal expansion. So that's MARPE. So MARME is mini implant assisted rapid maxillary expansion. It's just a difference in terminology. But the most common that you'll see in the literature and that what most people talk about is MARPE. But, just if people are reading things, MARME is the same thing. Okay. So now there's different types of MARPEs, right? So MSE, specifically MSE type 2, that is the most common type of MARPE and probably the most popular MARPE in the United States. And that's Juan Moon's MARPE. So it's a non-custom MARPE, meaning that it's just it's an appliance. It's basically an expander that has 4 lumens in it that you can put 4 screws in. And so you can customize it in that you can move it, right? You can move it forward, you can move it back. It's typically designed and placed by a lab, but the appliance itself is, it's not typically customizable. I mean, you could laser weld to it and customize it on your own, or your lab could customize it, but it's not like a custom MARPE like you'll sometimes hear about, okay? So the MSEs, and most of them are 4 screws. They do make a 6 screw version as we talk about in the course, but that's kind of MSE type 2. That's sort of like, you order a bunch of them, and that's kind of like a standard expander that works really well on a number of patients, all right? But there are limitations to that because it's not fully customizable, and we go over that in the course. Now, a custom MARPE, currently, the only company that I'm aware of that are doing them right now is Partners Dental Studio. And what that does is it is a MARPE, right? So it's an expander that has screws in the jaw. But with that, you can stitch the cone beam of the patient to the STL file of their teeth, and you can 3D design exactly where you want those screws to go. So basically, you can find the best bone and you can have them place those screws into the best bone. And then they'll also do the work of doing the measurements as far as how long of a screw you're going to need in this place versus that place. And then you can fully customize it to distalize molars or intrude this side versus that side. You can add stuff to the appliance. And so that's when they talk about a custom MARPE. Typically, they're talking about, Partners Dental Studio stitching the cone beam and the intraoral scan together and planning it out that way.
Okay, that's great, because I think sometimes it's a little confusing when there's both people. You might use MSE and MARPE back and forth, but MSE is a type of MARPE, and then there's
Correct.
different types within there. So in the course, you talk about different expansion appliances and techniques. So you kind of go through our RPE, rapid palatal expanders, slow turn, growth guidance, and then you get to MARPE. Could you talk a little bit about each type of expander and what they are, what they do, summarize the differences?
Yeah. So trying to keep it as simple as possible, and this is one of the challenges, right? Is because we all have a different name, but we all just call them expanders. But what I try to go through in the course and point out is that, expanders are not expanders are not expanders. The type of expander that you use really does make a difference depending on the type of goal that you have. Right. So, I mean, I've had patients come in and say, oh, yeah, my orthodontist expanded me. And I'm like, oh, okay, cool. Like, what did they expand me with? It's like braces and wires. It's like, okay, cool. And I'm not going to say that you can't expand somebody with braces and wires. I mean, Mike DeLuke's a great example of that. He shows a lot of, before and after cone beams. And, you do get some types of expansion with braces and wires. But my goal with going through the different types of expanders was to really highlight and understand what type of expansion you're going to get depending on what type of expander that you use. And so if your goal is dental expansion, meaning you're moving the teeth and not the bones, that's great. There's a lot of different types of expanders that have been shown to do that, right? I mean, braces and wires are most notoriously known for dental type expansion, although they can get some skeletal. Alpha appliances are mostly known for dental type of expansion, and depending on the age of the patient and whatnot, you may be able to get a little bit of, dentoalveolar bending and things like that. But really, when you're looking at orthopedic expansion, and that's really what most people are interested in obtaining when they're going and looking at MSEs and MARPEs, right? Or MARPEs in general. They want to get orthopedic expansion. So when we look at the literature and what provides orthopedic expansion, and just so your listeners understand what I'm talking about here, orthopedic expansion means that the entire 2 halves of the top jaw are separating and getting wider, okay? So, and that goes all the way up through the nasal cavity because, the top of the top jaw is the bottom of the nasal floor. So when we're talking about orthopedic expansion, we're meaning expanding all the way up the entire 2 top jaws. When you talk about that type of expansion, you really only have well-documented, a few types of expanders that do that. So traditionally it was all RPE, rapid palatal expansion. And then they found out over time that, depending on the age of the patient, you can still use, a rapid palatal type expander. You can turn it a little bit slower. And now they call it a slow maxillary expander. And that can provide orthopedic changes as well. And then there are even some lower force expanders than that. Leaf expanders, sometimes even quad helix, depending on the age of the patient, that can provide some orthopedic changes as well. So when it boils it down, what you have to understand is that there's not just one set type of expander that's going to work and provide, orthopedic or dentoalveolar bending or tipping. It's all very patient specific. But if you want to understand it in a comprehensive way, there's really only two things that are involved in knowing what kind of expansion you get. And that's going to be, the force applied and the resistance. Okay. So the reason that, so many people present so many different cases and, oh, well, I got expansion with this, I got expansion with that, is because they're looking at different patients. Different patients have different resistance. So when we look at a 4-year-old, for instance, we might be able to throw brackets and wires on a 4-year-old, or a quad helix on a 4-year-old, or an ALF on a 4-year-old, and you may get some orthopedic expansion. Okay. But, typically with an appliance, and I'm just using the ALF because it was the first thing that came to mind, with something like that, the forces are so low that you're much more likely to get dentoalveolar bending and dental tipping. Okay. So orthopedic is the bones moving apart. Dentoalveolar bending is a type of skeletal expansion, but it's much different than orthopedic expansion. When we talk about dentoalveolar bending, we're talking about the bone that supports the teeth. That bone is kind of moving along with the teeth as the teeth move. Okay, so it is skeletal, right? The bone's following the teeth. It's not just the teeth moving out of the bone. Okay, that's dentoalveolar bending. And that does account for a number of, a percentage of any type of expansion that you do. And in the course, we go through a case, and if you want, I can throw it up here, that really shows, what that looks like when you have a lot of dentoalveolar expansion and not so much orthopedic. And then the last one, and this is probably the least favorable type of expansion, in most cases, right? In most cases, it's just dental expansion. It just means you're moving the teeth. And although it's good because it does create more room for the tongue, a lot of times it can help with myofunctional goals. If there is a true skeletal discrepancy and you use an expander that only tips the teeth outward, well, yes, you're making more room for the tongue, but you're also pushing those teeth, possibly to the edge of the bone or even outside of the bone. And that's something that we want to avoid because there's long-term periodontal consequences. And when you're tipping the teeth within the bone, they end up, flared or tipped outward. And so from a stability standpoint, long-term, the forces of occlusion and everything else they're going to be doing throughout their life are not going to be upright and vertical within the bone as it's designed to be. And so that's kind of like the 3 types of expanders. And so our goal is to, depending on the goals of the case, pick the right expander in order to be able to get the type of expansion that we want. Now, as orthodontists, sometimes people don't understand, well, why don't we do ALFs? Why don't we do Healthy Start a lot? And like I say, I'm not against either of those things, right? It's just that if I want to get dental expansion and possibly some dentoalveolar tipping, my expander of choice would be braces, right? Or clear aligners, because it's easier. And I can get those type of results with either of those things. And so I would choose, not to do an ALF or not to do a quad helix, or not to do, Healthy Start appliances if my goal is to get mostly dental tipping expansion and or some dentoalveolar bending, right? And so that's why I choose to do it that way. But it doesn't mean you have to do it that way. If you understand what type of expansion you want and what your appliance is going to do for you, you can use whatever you want.
That was so good. Is it possible to get dental tipping, but not dental alveolar bending?
Yes, absolutely. So specific, and that happens a lot in adults, right? So if you, really, really push out and, a lot of and again, I don't know how popular or not popular that the AGA appliance is, but, people who have misused that, have ended up on the news, right? And it's caused some problems. And that's a problem of using an inappropriate force system to try and do something that physiologically can't be done that way. When you're trying to get orthopedic expansion on an adult with a lot of resistance, and you're using something that the only anchorage you have is the teeth roots, right? So if you're not anchoring to the bone, the only anchorage you have to the jaw is the teeth roots. And if you push on those teeth roots hard enough, yes, depending on the resistance, there may be some adults that you can actually, use the teeth roots and push it open and get a diastema even without mini screws, but it's very, very, very unpredictable and highly risky. As you see, if you watch the news, you'll see these cases where they just kept cranking, and they just pushed the teeth right out of the bone. So, that's dental expansion with 0 dentoalveolar bending and 0 skeletal. That's just pushing the teeth. Yeah, you don't want to do that.
This is so clear to me. And I think I didn't truly understand the dental expansion component and how there's 2 sort of breakdowns of that. So let me sum this up because this is great. There's 3 different types of expansion. We can get orthopedic expansion, which is actually the skeletal bones, the midline palatal suture, the skeletal bones widening. Okay, then there's part two, or another option. You can get dental alveolar bending, where the bones that house the teeth are actually moving with the teeth. And then you can get dental expansion, and there can be any combination of those. But when picking an expander, you have to pick what type of appliance you want to use, depending on probably the age of the patient, the condition, and considering force versus resistance. Is that a good
You said it even better than me. Yes, that's perfect.
It makes so much sense. And that's why certain people and ages are candidates for a MARPE type appliance. When we get orthopedic expansion, can you list some of the benefits of that versus maybe just the dental component, dental alveolar bending or tipping?
Yeah. What would be easiest is to list the benefits that you get from the dental alveolar bending in the teeth, because then all the other benefits are what you're only going to get through orthopedic expansion. Okay. So basically, the benefits that you get from an airway standpoint with dental alveolar bending and or dental expansion alone is an increase in arch perimeter and more room for the tongue. Right. And so any of those benefits from a myofunctional standpoint of getting their tongue up and out, and strengthening the muscles and having more room for it, you're going to get those benefits regardless of the type of expansion that you do, as long as you get that increase in arch perimeter. Okay. But that's really the extent of the airway benefits that you're going to get unless you get orthopedic changes. So all of the other benefits that you get from an airway standpoint are going to be from obtaining orthopedic changes. So one of the biggest benefits and one of the most documented and well-researched and most established benefit is a decrease in nasal resistance, meaning that it becomes easier to breathe through your nose after you have orthopedic changes. All right. So that's been well documented in kids and also well documented in adults. They do before and after a nasal rhinometry. So basically, in the vast, vast, vast majority of patients, you are going to be able to breathe easier through your nose if you get orthopedic expansion and your jaws become wider. And this really makes a lot of sense when you think about it, because it's the same bone. So as the upper jaw expands orthopedically, the nasal volume increases, right? The triangle gets bigger and you have more room. There's more space for that air to go in. I say the vast majority because there are a subset of patients where the soft tissues can swell and they can fill that space. And even though the box is bigger, they still have trouble breathing. And like I say, there's lots of reasons, and ENT, and like I say, you can have a lot of people on the podcast that could go into those details more. But by and large, 90+% of patients are going to breathe easier if they get orthopedic expansion. So that's kind of like number one.
Hey there, podcast listeners. Before we dive into today's episode, we have an exciting announcement for you. This podcast is proudly brought to you by the members of Airway Circle, the premier community for healthcare professionals passionate about airway health. By joining the Airway Circle membership, you're not only helping us bring this podcast and our professional directory to the public at no charge, you will also gain exclusive access to a treasure trove of knowledge with hundreds of expert lectures. Whether you're a seasoned practitioner or just starting your journey, our diverse range of topics covers everything from breathing, craniofacial development, myofunctional therapy, palatal expansion, to oral ties, sleep, and gut health. We would like to extend our gratitude to a few of our loyal listeners who share Airway Circle with their colleagues. To claim a free month of membership to Airway Circle, visit www.airwaycircle.com and use the code Airway Answers. But don't delay, because this offer is limited to 5 lucky individuals each month. And that's not all. As a member, you'll become part of a vibrant community of like-minded professionals, have the opportunity to learn from experts, participate in live Q&A sessions, and engage in discussions that will deepen your understanding of airway health. Don't miss out. Join the Airway Circle membership today and come grow with us. Airway Circle, where knowledge meets community.
And one thing about that is I had the MSE appliance and I was a nose breather. So I did not sit with my mouth open, sleep with my mouth open. But that MSE increased the nasal volume where I felt like I could breathe better through my nose. And I didn't know that maybe I didn't breathe as well through my nose, right? So you don't have to be a mouth breather to benefit from increased nasal floor volume. And when we decrease nasal resistance, we're decreasing collapsibility of the airway. So that type of expansion, that orthopedic expansion, could benefit any sleep disorder breathing patient, even if they're not a mouth breather or feel like they can't breathe well through their nose.
I would just be careful with the word any. And the only reason I say that is because, sleep disorder breathing, I mean, you really cannot loop them all into one bucket. You can loop them into the majority of the bucket, right? So the majority of sleep disorder breathing patients, it's collapsibility, and most likely in the tongue pharyngeal area, sometimes higher up. That's the majority of patients, but there are a number of sleep apnea patients. They can have epiglottal stenosis. They can have, obstruction in another area, or they can have central sleep apneas. And so I wouldn't say any, but most or many of the sleep disorder breathing patients are going to benefit from orthopedic expansion. That is true.
Decreasing that, like the threshold for that collapsibility, opening that tube, that breathing tube
Correct.
Wider at any component.
Well, and while you're talking about that, so we talked about the nasal part of it, but what else is important to understand is the maxilla is, it's a broad bone. I mean, the maxilla is, yay big or whatever in your mouth. So as that's expanding, everything that's attached to the lateral walls of the maxilla, so the lateral walls of the pharynx are attached through the soft tissue to the maxilla. So as the top jaw gets wider, all of the pharyngeal walls, what holds the palatine tonsils, that all widens as well. And it's not like a one-to-one. It's not like you get, 10 centimeters of expansion. Oh, look, it's 10 centimeters apart. But what we see, especially in growing kids, is that, you get the width there over time. Those soft tissues tend to remodel and become wider over time, accounting for more of the increase in the posterior airway, specifically behind the tongue and in the area of the tonsils. And so that's kind of like a secondary benefit. The nasal breathing benefit is almost immediate. I mean, that happens right away with the change. And then we tend to see more of the posterior walls expand over time as essentially the body adjusts and continues to grow if you're growing, or if not, continues to adjust as an adult. And basically that wider jaw, helps to provide a wider posterior airway also.
Okay, when we're talking, and in the course, they talk about like more of a triangular expansion and how the anterior expands more than the posterior aspect in any type of expansion that's orthopedic?
Yes, there's always going to be a portion of the expansion. It's never going to be 100% parallel. Mm-hmm. All right. And the reason it can't be 100% parallel is because the resistance is never zero. Okay. You know what I mean? There's always going to be resistance in the maxilla, and where that resistance is at the skull. So you have I should have brought my skull. You have your maxilla, and then you have like the rest of the skull back here, right? Well, the maxilla is attached to the skull back here. So the resistance is always posterior to where the maxilla is. It's also superior, right? The maxilla attaches, up here at the frontal bone and the nasal bones and the zygoma. So all these places where the maxilla attaches, where the resistance is happening, meaning the forces fighting against your expansion, are all back here and up here. So there's always going to be more expansion down here where there's less resistance. So from a vertical standpoint, you're going to see triangular expansion like this. And from an AP standpoint, because the resistance is further back here, you're going to see, more in the front than in the back. Now, when we talk about, we want parallel expander, or this expander, provides more parallel expansion than this one, there may be some truth to that. But I think that the biggest component of getting, more parallel expansion, meaning if you measure it ANS, which is at the front of the maxilla, and you compare that with the expansion at PNS, which is in the back of the maxilla, you want those numbers to be as close as possible, right? And the closer they are, the more parallel, quote unquote, expansion that you got. And so, yes, there are some cases that, a complication is splitting the maxilla between the maxillary bone and the palatine bone, which the palatine bone is behind the maxillary bone. So if you split the front part of the maxilla and the maxillary bone splits from the palatine bone, you may get zero expansion at PNS and in the back, and all of your expansion in the front. Like, that would not be good, right? We don't want to shoot for that. So however you design your expanders, and specifically your MARPEs, and specifically in adults, you want to design it in a way that you can try and get parallel expansion, and the back part of the maxilla is going to open up as close to as much as possible as the front part does, even though the front part's always going to open a little bit more.
That totally makes sense. And that was a really great explanation with the resistance at different parts of the bone. That makes sense as to why the expansion is not necessarily parallel. Okay, I don't want to back up because I want to move forward, but I got to back up. I have a question. Okay. Just for my knowledge, I've heard of people saying with the RPE, slow turn versus fast turn with RPE. Can you just explain that a little more?
Yeah, I'm glad you brought this up, because this is such a huge source of confusion, not only among, all of your listeners, but in the orthodontic world as a whole. Like, I've asked multiple orthodontists, I asked them, well, what's slow maxillary expansion? Define it for me. Pretty much like nobody can. And certainly there's no consensus on what it even is. And when you look at the research on slow maxillary expansion, there's so much differing information. But I'll try to break it down as simply as possible from where we're at today. So rapid palatal expansion, if they ever got a bad name, it was back in the day when they were doing multiple turns per day on very young kids. So when you go back and you hear research like, oh, Prophet talked about how maxillary RPEs can mess up the nose, and things like that, it's true. If you expand too fast in too young of a child, yes, there can be, malformations and problems at the growth plates. So that's something that we discovered, years and years and years ago that you shouldn't do. Okay. So since then, rapid palatal expansion has, transformed, and we've understood that when we do rapid palatal expansion, it doesn't have to be 4 turns a day, 6 turns a day, which is, equivalent to a millimeter or a millimeter and a half per day. We can do rapid palatal expansion at 1 turn per day, which is about a millimeter and a half per week. And in many, 7+-old-year-olds, that's going to work just as well in the long term as if we were turning it 2 times or 4 times or 6 times. Now, understand, I am oversimplifying it, right? Because again, we have to always think about the anchorage and the resistance. So you could put an RPE on a 10-year-old, but if they only have first molars in, and that's the only anchorage that you have, and you can't attach that expander to anything else, you might not get the same type of orthopedic expansion, even though you're using a quote unquote RPE. That's just an anchorage problem. But by and large, modern day, I would talk about rapid palatal expansion as really anything 1 turn a day or faster. Okay. Like once you start doing less than 1 turn a day, like down to maybe like 1 turn a week, then it's more considered slow maxillary expansion. And the irony is that, when a lot of people think like, oh, rapid palatal expansion and slow palatal expansion, they're different. And the only way that they're really different when you look at the research is the rate of turning, right? It's still the same type of appliance. It's just, are you turning it faster or slower? But the confusion comes when people start looping a lot of other things into quote unquote slow maxillary expansion, like quad helices, like alpha appliances, like all these other things that are out there that can provide expansion. They call them, slow maxillary expander. Oh, this is a slow maxillary expander. But that's not necessarily what the research accepts as slow maxillary expansion. When you look at the vast majority of the research, slow maxillary expansion is the same type of expander, just turn slower, right? And then if it's one or more per day, then it's rapid. Yeah.
Yeah, that's great. And then is there a benefit or a problem? Like, is there a benefit when you do 1 turn a day or more, but not too many, right? Not many turns a day versus the slow turn where you don't do a turn every day in a young child? Are there benefits or negatives with either of those?
Yeah. So the biggest benefits of doing slow maxillary expansion, and the reason that it has become more popular and there is a significant amount of research behind it, is because it limits complications, right? And it's typically easier on the patient. So the slower you turn the expander, the less uncomfortable it will be for the patients, if that makes sense. And that plays out even more the older you get, right? So if you're 12 years old and you're turning an expander slower, then that's going to be more comfortable because the teeth and the bone have more time to remodel it and adapt to the changes that are happening. Okay. Now, with the rapid palatal expander, the problem is you're always juggling the type of expansion that you want to get with the type and protocol of the expander that you're using. So I've had patients transfer in that had, slow maxillary expansion, and they were turning this thing like once every 2 weeks. And they were young. I mean, they were like, 10, 11 years old. But when I look at their imaging, like, there was not much orthopedic expansion at all. It was mostly dentoalveolar bending. If you want, I can put this in the notes if people want to look at it. I can show you a case where you have an extreme amount of dentoalveolar bending. If you can envision it with me, picture like, your square box of the maxilla. And then at the very bottom where the teeth come out, it's just like it's stretched like Play-Doh. You know what I mean?
And
it just
show that? Totally
yeah.
pull that up if you want to show
Let me pull it up real
because
quick
it's good to just visualize and see the difference if one of the listeners is actually watching this versus just listening.
Absolutely. I'm going to share my screen now here.
And also after you talk about that, my brain is going to, I see some practitioners use removable expanders where it almost looks like a Holly retainer, but you turn the inside, and maybe you could talk about that a little bit as well.
Yeah, I think you have to enable the screen sharing. It's saying it's disabled.
Oh, okay. So let me do that.
But let me comment on the removable expanders in general. Okay. So removable expanders, again, just because it's a removable expander doesn't mean that you can't expand with it. Okay.
Try again for screen share.
We'll try again for that. Okay, awesome. Let's screen share, and I'm going to share this one here, and we'll share that. Can you see
it's
that?
Coming up right now. Yep, there we go.
Hit play. So, okay, perfect. Is that big screen now?
Yep.
Okay, so this is the most extreme example I've ever seen of both dental and dentoalveolar bending. So you can see the dental tipping, you can see the angulation of the teeth, right? So the molars on the top, and just to orient you a little bit, this is a person like looking out of the screen, right? So it's as if they're looking out at us, and it's kind of a cross section right in the middle. And we're at the level of the first molars. So what you're looking at is the first molars chopped in half, sideways, if that makes sense. Okay. So the eyes are up here. Can you see my cursor?
Yep.
Yeah. The eyes are up here, the nose, these are the sinuses. This is the maxilla, and these are the teeth. So the first thing to note out here is, do you see how thick the bone is in the midline?
Yeah.
Yeah. So that's going to have a lot of resistance, right? So the more bone you have, the more resistance there is, because that suture is interdigitated. So when we're trying for orthopedic expansion, we have to overcome all of the midline skeletal resistance before we can start moving the bones. Okay. So like obstacle number one is you got to get the maxilla to split. Okay. If you don't get the maxilla to split ever, then you're not getting orthopedic changes. It's all going to be dentoalveolar and dental tipping, which is what we see here. So do you see how these teeth, they're still within the bone? There's bone on the buccal, there's bone on the palatal, on both sides. They're still well within the middle of the bone that's there. But do you see how tipped out they are and how the bone just sort of followed it? That's dentoalveolar bending.
Teeth are diagonal. They're not upright in the bone. They're diagonally sticking out, basically.
Correct. Okay. Correct. So when we go to treat this patient orthodontically, we're going to need to upright those teeth. Now, in this case, there is bone there to do that. You can imagine like here, if we upright those teeth, yes, the buccal of the root will be closer to the buccal plate of the bone, but there's bone there to upright them. So we can keep them within that bony housing and we can get those teeth to fit together. But my point is, if this patient needed true orthopedic expansion, which, I would argue maybe they do, at a minimum, they need to be nasal breathing, right? You can see the inflammation both in the nasal cavity and the sinus, specifically on his left side. That is not going to happen if the expander you design is not sufficient to overcome this midline maxillary resistance and provide that orthopedic change. So this was a quote unquote slow maxillary expander, and this was done by an orthodontist. My guess is that, like most orthodontists, they have never been taught this. They've never been presented the research and understood this in a way that they can make this predictable. Yeah. I think that with AI, this will be a new standard. Like we'll be able to send in a cone beam and the AI will show us where the resistance is and where the bone is and how much we need. And will these tooth roots be able to provide the resistance? And if so, how much force is there going to be needed? Like in the future, I think that's where this will go. And then we'll know you can use this type of expander, but if you do, you need to cover this many teeth and you need to have this much grams of force, or you need 2 TADs or 4 TADs or 8 TADs, if it's an adult. I think that's all something that can be calculated. Yeah. It's just that at this point, it's so complicated to do that we can't. We just guess, right? So we look at the midline and we say, okay, that's pretty thick for a 10-year-old. I think I'm going to have more resistance. So maybe I'm going to err on the side of, possibly even doing an MSE on this patient if, depending on how critical the needs of the expansion are and how much of it needs to be orthopedic versus skeletal. With a traditional, RPE, bonded RPE, Hyrax, all the ones you see in the literature, at best, when you're done, at best, you're going to get about 60% skeletal expansion at best. All right. So that's like a younger kid with not a lot of resistance. When it's all said and done, only 60% of it is going to be orthopedic. A lot of the new research coming out on MSEs is showing that we can get up to 90% orthopedic change when we anchor to the bone, that it's long-term stable. And so that is a true game changer, because if you don't need the dentoalveolar tipping and or the dental tipping, then you can use something like MSE or a custom MARPE, and you can predictably get just the orthopedic change that you're looking for. And up to, until these came out, we couldn't do that. There was no way that we could do that.
There were so many great points. If you leave this slide up, using a rapid palatal expander, 60% orthopedic change versus at best versus a TAD implanted or MARPE MSE, 90% at best, would you say?
At best, yes. At best, yeah.
Which is very significant. So this case that you're showing on the screen where the upper teeth are tipped and need to be uprighted, how would this orthodontist who did this case finish this off so the teeth are in alignment?
Yeah. So here's the thing is when you look at how big the top jaw should be, it really shouldn't be bigger than about 5 millimeters larger than the mandible. But most of the time, in most patients that are going to come through your office, their upper jaw is going to be either the same size as their mandible or smaller. So you can see here how I'm measuring it. I'm measuring from the middle of the basal bone of the maxilla that's going to be housing the teeth. Okay. That part of the top jaw should be 3 to 5 millimeters wider. That's how it always used to be, or at least mostly always used to be. When you look at, prehistoric skulls dating from, 300 to 500 years ago and back, that's how it was. You can go into all that and why we don't see crowding. And we don't have to go into that discussion, foods, eating, all that stuff. But basically, our goal is to get the top jaw 3 to 5 millimeters wider than the lower jaw. So in this case, we actually have overexpansion of the dentoalveolar complex. So the bone that houses the teeth is actually too wide. You can see it's 55 millimeters. Okay. And the lower jaw at the same level is 44 millimeters. So ideally, that part of the bone would have only been, 50 millimeters, maybe at most, 5 or 6 millimeters bigger than the mandible. And when it's like that, we can upright the teeth within the bone and we can have the top fit on the outside of the bottom, not in a crossbite, in a harmonious relationship, minimizing or reducing the chances of long-term bite and, jaw problems down the road. So that's what we're shooting for. So how do you finish a case like this? It's very challenging. We have to compensate, is what we call that, in order to get these teeth to fit together. So when this case finishes orthodontically, those upper teeth are actually going to have to be tipped in a little bit. And the lower teeth, rather than being upright, are going to have to tip out a little bit. And that's the only way we're going to get these to fit with where these bones are, right? I mean, hindsight's 2020. I mean, if we could go back and get more orthopedic change in this patient, but yet not the dentoalveolar and dental changes, that would have been ideal, in my opinion. But again, it's never perfect.
The orthodontist who did this case would probably finish it off, or if you got this patient, would finish it off by reducing some of the dental expansion on the upper,
yes,
and then doing a little dental expansion on the lower to make things line up. Okay.
Correct. Yeah. You might get a little dentoalveolar bending. I mean, depending on the severity. And again, this is a kid, so most likely that would be what we would do. We would just tip the teeth inward. Would the dentoalveolar bending go back the other way? Maybe. That's actually a great question. No one ever talks about that. Like, we never try to constrict the maxillary arch because this is not natural, right? You would never have a patient naturally come in like this. The only reason they're like this is because of the expansion that was done. So, but that's an interesting question. I mean, in theory, if you bring the teeth in fast enough, it should bring some of the bone back with it. It should bend the other way. That may be, helpful in trying to address this. But yes, to answer your question, yes, we're going to move the teeth. Any dentoalveolar bending we might get with the appliances that we use, might help a little bit. On the lower, as you upright, you might get a little bit of dentoalveolar bending there. But yeah, you're just going to try to get the teeth to fit together as best as you can with where the jaws are.
And this is why this is such a team approach, because if you had an ENT here, you're there, me, myofunctional therapist, ENT would see the sinus and nasal congestion like we all see because we're all educated in this. You see teeth, I see tongue, right? Yeah, I see low tongue. Yeah. So we all have to be aware of all of our specialties and all these multifactorial problems our patients have and see the big picture, because of course this practitioner was just treating teeth. And I don't know if they were attending to tongue or nasal breathing, ENT medical components as well. So that's a great case and a great way to show the dental alveolar bending and dental tipping versus orthopedic changes. So thank you.
While we're on that, I'll just show you too. This is Juan Moon's research. This kind of is what I think will become the standard of care for how we measure this. So you can see here, they're taking before and after cone beams. This is an MSE patient, so you can kind of see the triangular shape that we talked about with the expansion. You can see the split of the diastema here, but they measure it in 3 places. So they're measuring the orthopedics expansion, looking at the actual zygoma here. And then you can see they measure a little bit further down to get, again, another idea of how much the top part of the jaw is widening compared to the bottom jaw, or compared to the bottom portion of the jaw. And then at the end, they measure the middle of the teeth, which is going to give them their dental measurements. So there are ways to calculate out these 3 things. And this is where I think we're going as a profession from a research standpoint, because if we're comparing apples to apples like this, well, now we can actually start having that conversation about what types of expansion we're getting, what types of expander we're using to get that type of expansion. And then we can work that back to, how much force do we need in order to overcome the resistance? You can see here, this is an older patient than the one I just showed you, but look how, relatively smaller that midline resistance is in this patient, compared to this one here where it's much thicker. Again, you can't treat that with the same type of expander and expect the same type of result.
Yeah. And like you said, this will be an AI thing at some point where you're sending your CBCT image, right? It assesses the whole face from the nose, sinuses, all the way down, and says what the patient needs.
Right.
I feel like that. I could see that.
Yeah.
Interesting.
Any residents out there looking to do research,
Anyone want to be a bajillionaire, right?
Exactly. Figure this out. Figure this out. We'll all buy it from you.
Yeah, with that sort of, I know Dr. Harrell is doing like a 3D facial analysis where you take a picture with your phone and it can analyze that. But yeah, put all that together, you send it off. It tells you the appliance options, the resistance at the midline, the goals, send this patient to ENT for some formula. I feel like that could be really an interesting thought for the future, and probably not so far away, right?
I would hope not. I would really hope not.
Question: after patient gets, so if you want to, do you want to stop the share?
There we go.
After a patient gets that sutural split, do we know it's bone that's filling in? Someone asked once, is it cartilage, or how do you know it's actually bone?
Yeah, I saw that question, and I haven't done a dive into the literature, but it doesn't really make sense to me that any cartilage would fill in that area, just because there's not a lot of cartilage in that area. The nasal septum is above an endothelial layer, so like there's quite a bit in between there. So if anything, if you didn't have bone fill in there, you could potentially have some normal, bone, like a scar that could happen, or some keratinized tissue from the palate or something. I'm not aware of this being a big thing. I mean, typically, by and large, yes, it fills in with bone, just like when you break a bone. Like, I mean, you could ask the same question about like, well, how come when you break your arm and, and they put it back together, it fills in with bone? I mean, it's because there's bones there. You know what I mean? Like bone. I mean, that's what usually fills in. I mean, maybe what they're asking is like, if you expand too fast, now the two pieces of the bone are too far apart and just whatever fills in there, is that possible? Yes, it's possible. But I mean, there's quite a bit of before and after cone beam imaging that shows that, and in every patient that I've ever seen, I've never seen anything fill in there except for bone. So, I mean, if there's something specific that they are wondering about or know about, I mean, I'm more than happy to look into it, but this is not like a common problem. I would say the most common problem that you do hear about is not that bone doesn't fill in. It's that, with these piezotome osteotomy procedures, you can create a situation where you have air, where nothing fills in. Basically, you have a communication between the nasal passageway, a fistula, and the oral cavity. And that can happen as a complication to like, piezotome procedure gone wrong, and or, communication between the nasal passageway and the oral cavity. It happens a lot in cleft patients as well, where you have holes between the nose and the mouth. And so that's not good, but that's not to be expected with normal expansion, meaning that if there's not soft tissue open in one cavity or the other that shouldn't be open, then that should never happen.
Okay. And then the suture fuses just naturally, the midline palatal suture. Can you kind of talk about what ages that begins to fuse? Yeah.
So basically, and fuse is the word that is commonly used, but basically about 4 years old is when it kind of, and I'm not going to talk about fusion. Let me talk about it this way, because I think this way is a more valuable way to explain it. We really want to understand when the resistance is increasing the most significantly. All right. Because again, it boils down to the resistance. So, basically birth to 4 years old, there's not a lot of resistance in the maxilla. And you know more about that with babies than I do. I mean, the craniosacral therapist and moving with the thumbs and everything, like, I'm like, wow, that's cool, but that's not my world. I don't really know a lot about that. But, suffice it to say, from 0 to 4, there's not a lot of resistance in the midline maxillary suture. And from about 4 until about 13 to 16, depending on the patient, is when the majority of the resistance is increasing. And so you can call it fusing. Most of the research that's out today really describes it more as an interlocking. Some of the slides we go through in part 1 demonstrate that on diagram form and on the histogram with the slides. But basically between 4 and about 13, the resistance is increasing. And I would say, the most significant increase, or when it really starts to get more difficult to get true orthopedic expansion, is probably around the age in most kids of 9 or 10 and getting older. So at 9 or 10, it's like, okay, it might be a little bit more difficult to get true orthopedic change, and or I might need to be more proactive about planning my expansion with better anchorage to make sure that I'm getting the orthopedic changes that I want to see. The other challenge with 9 or 10-year-olds is a lot of times they're losing teeth. So, the baby teeth roots are short. When they're 6 or 7, the baby tooth roots are big, and those things are solid in the bone, right? So you start expanding on those and you can get great expansion, but now they start to lose the roots of the baby teeth. They start to dissolve. Now, if you put that same expander on a 9 or 10-year-old and there's only, little bitty baby tooth roots left, and that's what you're covering, well, now your anchorage has gone down significantly. So by the time, the sutural, fusion is not really complete until you're done growing in adulthood. And they found that the level of resistance is not the same for all patients. So it doesn't always go all the way from, to complete sutural maturation. They call it stage E. it doesn't always get to that in every patient. Some people stop at stage D. And at this point, there's really not a really easy way to just look at a cone beam and say, oh, this patient went all the way to stage E. This one went to stage D. This one, barely got out of stage C. But it does impact the amount of resistance you have. And this is where, again, AI would really help us. If they were able to analyze the data in a cone beam in a way that we couldn't, right? And process that in a way that's meaningful. Well, now we can get a resistance number, regardless whether it's stage E, stage D, or how much it actually fused together. And I didn't mean to get too deep into the weeds, but I always hate answering questions simply in a way that like, oh yeah, that makes sense, but it's not like complete. You know what I mean? I don't want to give your listeners an impression that something is true that isn't. I mean, so sometimes it's complicated.
That was such a good explanation. And for me personally, I don't remember things unless I know all the details or like, it makes sense. And I'm like, that's really important because the pictures in the course, and I've seen this elsewhere, it's not like a line that just like fuses together, but it's kind of like an interwoven bones, right?
Right.
Like, I guess it's interesting that there's different resistance at different ages. When you've reached maturation, different people have different amounts of resistance. And is there ever an age or a person that you cannot become successful with a TAD expansion due to the resistance, or how do you work around that?
Yeah. So that question is still to be determined. There are many MARPE practitioners, myself included, Dr. Ting, Dr. Lipkin, Dr. Evans, that talk about, pretty much being, with sense piezotome. All right, sense piezotome and being able to reduce resistance. And Mariana is probably an outlier here because she doesn't do piezotome. She prefers to do only TAD supported, but she designs her appliances very, very well. But to answer your question, a lot of us have not encountered patients yet that we couldn't expand skeletally. Now, there are a subset of patients that, at least me personally, and I'm sure the other practitioners are similar, where we choose not to even attempt it, right? Because like if there's a high chance of complication in that patient, then the chances of those complications are not worth the risk of expanding, if that makes sense. So there are patients that when I review the anatomy, when I look at the cone beam, I say, look, this bone, this is paper thin on the lateral walls. Like there's a high chance that could fracture. There's not a lot of good anchorage. Like I don't even have places to put TADs. And so I'm not going to attempt skeletal expansion on that patient, at least until we have better or more information that says, okay, yes, the formula works out and we can do it. So there are many, there are not many, but there are, a few patients that have come to me where I've said, I don't feel comfortable doing an expander on you, and this is why. But out of the ones that I have attempted since I've had the ability to do the osteotomy and release essentially the vast majority of the midline resistance at delivery, I've not had a case that won't expand. And I believe that, at least from what I've heard from Dr. Ting and Dr. Lipkin, they're experiencing the same thing. It's like if I attempt the patient, like we typically, essentially always have gotten expansion using piezotome to help reduce the resistance at the midline. So I don't know. Is there patients out there that can't split? I would say yes, there probably are, but I can't give you a description of what that patient looks like. And until we have enough cases attempted to do that, then we won't know.
Could you explain a little more about piezotome osteotomy?
Sure. Yeah. So piezotome osteotomy, basically it means that you are doing a midline incision down the middle of the palate and you are literally cutting the bone in half. And so it sounds like really, really crazy and aggressive, but we talk about the details in the course. The tip that we use with the piezotome is a 1/4 millimeter thick. And that's important to me. There are other piezotomes that use, 1/2 millimeter thick or somewhere in between. And, 1/4 millimeter, 1/2 millimeter, does it make a big difference? Maybe, maybe not. But from my standpoint, it does make a big difference in potential complications. For starters, like one, the further apart that bone is to start, to your point about wanting union of the bone, and not having a non-union incidence, because you do have to cut the top of the palate. So there is a hole that leads into the mouth. So if you don't want that hole to get bigger and cause a non-union problem where they have to then go in and graft and fill in bone that didn't fill in, you want the smallest gap possible. Okay. So yeah, 1/4 millimeter is the burr that I use. And basically it goes through and it creates a 1/4 millimeter saw cut down the middle of the palate. And the goal is to cut as much of the palate as you can without cutting stuff you don't want to cut. Like you don't want to cut into the nasal cavity. You don't want to cut into the nasal septum. So I'm always a little bit conservative with that. I don't even go through the second cortical plate. I go through the entire first cortical plate and into the basal bone as much as I can. I swing back and get as much of the palatine bone as I can, but I don't go all the way to the end of the palatine bone because I don't want to, poke it into their throat. And then I very seldom do an A&S cut, which is the one in the very front between the front teeth. And again, the reason for that is that usually the problem is not getting expansion in the front. Usually we always get expansion in the front. So if I design my expander well,
least resistance in the front, right? Least resistance.
In most cases, yes. In most cases, well, once the midline is split, there's no resistance in the front, right? It's all apart. But when you're initially splitting the maxilla, you have midline resistance, and there can be more midline resistance in the front. But the goal of orthopedic expansion is splitting the palate. As soon as you split the palate, all of the resistance is up top and behind, right? So, but before you split the palate, you do have to pay attention to the midline resistance. So yes, there is resistance in the front part of the jaw where those two pieces come together. And in some patients, it's more than in other patients, but it's an area that I, at least to date, have not had to split with a piezotomy in order to get it to split on its own later. So typically I won't, because there's a lot of things that can go wrong when you do a piezotomy in the front. The roots of the anterior teeth are there. So if you get too close to those, you can have devitalization and or sensitivity. If you cut too far down, when you're expanding, the part of the bone that connects to the teeth, the PDL connects to the tooth, the part of the bone that connects to the PDL can split off of one tooth and travel with the maxilla on the other side. That can also happen if you expand too quickly. And so there are just a number of complications that I don't want to deal with. And so I choose to let Mother Nature break apart the bone in the front via the forces of the expander. And the protocol that I use is very conservative in nature until that split happens, because I want to make sure that, I'm minimizing the risk of complications. Right. And so that's why I do it that way. So the piezotomy osteotomy in my office, is on the palate. So it'll run from, kind of the front part of the palate all the way to the back part of the hard palate. So I don't go into the soft palate. Like I'm not, I don't want to have to suture everybody up and do all that kind of stuff. So it just goes straight down the palate in the middle, and we relieve as much of that midline bone to reduce the resistance in the middle as possible. So anywhere that I don't cut is going to be the part that the expander has to work to, overcome the resistance. Okay. And so back to your point about how the suture works in the interweaving, my protocol when I do an expander, a MARPE, is to activate it at delivery. So I want there to be force on the bones. And in my mind, like these bones are starting to pull apart. These interwoven portions of the top jaw in the middle are starting to pull against each other. And when you push bone against each other, it starts to resorb. And so I give that 5 to 7 days to start happening, to allow that physiology to start pulling that suture apart. And then after that first 5 to 7 days, then I'll have the patient start turning, but I never prescribe for them. I never say, do 2 turns a day, do 3 turns a day, do 1 turn a day. I tell them do up to 2 turns a day. And I tell them the force should never be excessive. It should always be a moderate force. So if you crank that thing only 1 turn or even a half a turn, and it's like, whoa, that's a lot of force. Well, you're not ready to turn again yet. So don't just do 2 turns because, we think we should do 2 turns, right? It's a process. So I try to educate my patients to understand what's trying to happen. I also explain, why they shouldn't turn too fast after the split of the maxilla occurs, because some patients want to do that. So they think they can get their expander off earlier, but that can cause problems. So I always tell them up to 2 turns a day. So if you're not feeling a ton of resistance, sure, go up to 2 turns. I mean, the body's telling you that the resistance is not, sufficient yet. Once you feel that moderate level of resistance, just stop and wait till the next day and try again. And following that protocol has been very successful in my practice to, again, help minimize the complications and maximize the amount of patients that get the orthopedic changes that we're looking for.
The patient can feel that pressure. You them. Oh, yeah. And I felt when the suture split. So this will be interesting to talk about who needs the piezotomy, who doesn't, what that feeling is. But I have a question. You said when you install it, you do the turns right then, and then you have them not turn for 5 to 7 days and then start the protocol of up to 2?
Correct. And the reason for that is that, there is a number of physiological things that have to be in place in order for that bone turnover to be efficient, right? So when you first do that injury to the bone, the body has to recruit all types of healing cells to that area, the osteoclasts, the osteoblasts. And so unless you give it time for all of that physiology to be in place, the rate of, bone turnover and healing is going to be slower. And so you give it, 5 to 7 days just to allow the body to respond and get all of the players in the game, so to speak. Okay. And then once all those players are there, well, now you can turn and you can start to have a more efficient, physiology happening, if that makes sense.
And is that only when you do the piezotomy that you wait the 5 to 7 days, or even without the piezotomy?
So I only wait the 5 to 7 days with the piezotome because by and large, the vast majority of adults that I do, I'm almost always going to recommend piezotome, and I don't require it. The reason I don't require it is because I don't want anybody to feel like they have to have that procedure in order to get expansion. And Mariana Evans is a great example of this. She doesn't use it and she gets great expansion in adults. What I tell my patients is, if you don't want to do the piezotome, then if we need a second expander to get the expansion that we want, then you'll cover the cost of that, because the chances of us needing a second expander go a lot higher if the resistance is higher. And if you don't do the piezotome osteotomy, the resistance is higher. That's the way that I do it. As far as the, not doing the loading period with the expanders, you actually bring up a good point. You could make an argument that would be a good idea, right? Just, start turning it a little bit, and because the same physiology has to be there and it's not naturally going to be in the midline palate. So I just do so few of adults that don't do the osteotomy that I haven't really thought about it, to be honest with you. That's actually a really good idea. I might start.
I wasn't even bringing up a point. I didn't even think about that. I was just wondering,
it's a great point, because the same physiology has to be there to basically split the palate as needs to be there to heal the osteotomy site and continue to split the palate. So that's a great point. And it's different because it's not used.
Yeah, with the osteotomy, it's probably a lot more like trauma to the bone. So I see why you'd probably want to give it more time than if you have an osteotomy. About the osteotomy, the piezo from your course, you said reasons why you may use it is to reduce the skeletal resistance, which of course makes sense at the maxillary midline, to provide more predictable expansion, maybe less side effects, maybe better expansion experience. So patients might not feel like the ripping or when the suture splits, they could tolerate that process better, which I definitely felt when the suture split, because it was before piezo was a thing, I guess, for this procedure. So I had the cortipunctures. So the night the suture split, I definitely felt that when that happened. Yeah, I called it was very weird. I called it a palate labor, because I woke up in the middle of the night with like throbbing between my front teeth, this like throbbing. And I was coming down to the wire where the expander might not work and I might need a surgery. At that point, that was the option, because it was a few years ago, but it was this throbbing between my front teeth. And I had been trying to eat really hard, crunchy foods. I'm like, I'm going to get this suture to split. And I'm eating like Love Crunch cereal, granola, carrots, like biting with my front teeth. I don't know if that helped, but after doing that all one day, that night, the throbbing occurred. And I was like, oh my gosh, I feel like I need to take Advil. Like, this is really bad. And then all of a sudden my nose started running like crazy. I'm like, do I have a bloody nose? Like, I never get a bloody nose. Like, no bloody nose. It was just clear, like just running. And then it stopped. Went away. I woke up in the morning and I had a little diastema. I was like, oh my God, it was like my water broke, like my nose. And then it just split. It was like a labor thing on my palate. It was totally a random weird thing, but that's how it happened. So I felt that. And I know patients sometimes feel it really strongly or whatever, but with the piezo, they're not going to obviously feel that because you've done the split for them. So when do you choose to use the piezo? Is it a certain age?
Yeah, non-growing patients. Yeah, so pretty much for me, if it's like non-growing patients, almost always that's what I'm going to recommend. And again, it's just a predictability thing for me. And so it's like, if can I expand you without doing it? Yeah, probably so. It might take a couple expanders, but we can probably get there. But back to your point about the complications, and this is something we need more research about. But, one of the most problematic complications is a fracture somewhere that you don't want it. Okay. So maybe it's a fracture between the palatine bone and the maxillary bone. Maybe it's a fracture between the maxillary bone and the frontal bone, or maybe it's a fracture between the back of the maxilla and the pterygoid plates. But most of the time, we have a fracture that we don't want. That's not a good thing. Take the pterygoid plate one out of the conversation because that's a bigger conversation. But let's talk about the other ones, like maxillary to palatine bone. If you have a split of either both or one sides of the maxilla and the palatine bone, that means that from your first molar forward, that portion of the jaw is going to expand. And from your second molar back, it's not. Okay, so that's a problem. Can create big asymmetries, right? So if I'm going to do I can't predict or tell you what the resistance is between the maxillary and the palatine bone. And if that's less or more than the resistance between the two palatine bones in the back. Okay, so two ways to address that. Either one, I can make sure I put 2 screws in the palatine bone all the way in the back so that I'm at least screwed to them so that, as I'm expanding, it's putting force on each of those bones individually. But when you look at the anatomy of the palate, that's pretty far back there. And in some patients, all the way back into the soft tissues almost. And so not every patient, you might not be able to get 2 screws into the palatine bone unless you're trying to drill through soft tissue and soft palate, which is going to be super uncomfortable. And in general, it puts it pretty far back in the palate. So that can be challenging, right? So if I go in there and I'm using a piezotome and my incision is in the hard palate, but I can rock that tip back and get into the palatine bone, at least I'm reducing some of the resistance in the midline of the palatine bone so that when we start turning, there's less resistance at that suture. And the chances of the suture breaking between the maxillary and the palatine bone goes way, way down, right? So now the chances of that happening are reduced, all right? So another thing is the pressure that happens up in the nasal bone between, this became famous on Reddit. I don't know if you saw that patient that had an expander. They had, I think it was an MSE, it might've been a MARPE. This was years ago. And basically one side of their entire face, all the way from the cheekbone down, expanded, and the other side expanded much less or didn't expand at all. And it created a situation where literally from the cheekbone down, you could see the eye. There's like more, if you search it on Reddit, you can find it. But, the eye is down like this, the cheekbone is down like this, the maxillary is, it's canted down to the side. It's a big problem, right? So when we have what's called a maxillofrontal or a maxillonasal suture split, that's not good. That's a complication that we pretty much have to stop and sometimes even back turn. And we get, so I'm going to do everything I can to avoid having that. So in my mind, and again, there's not a lot of good research on this just because there's not a lot of good compiled data on the number of cases that this has happened on to be able to really analyze it. But in my mind, the only thing I want to break apart is the midline palatal suture. Like that's it. Like that's really the only thing that I want to break apart completely, from the maxillary bone all the way down to the palatine bone. I want all that to separate. Everything else I don't want to break, right? So once I get that split of the palate, this is a finesse game after that. Like after that, it's always up to 1 turn a day. And the same rules apply. Like if it starts feeling like it's excessive pressure, don't turn that day or back turn it once. Like take your time, because all the other bones have to bend. Bending is the only thing you really want to happen, right? So if you start cranking too fast, you are at risk of, overcoming the resistance at one of the other sutures, whether it's here, 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 back here, and having an unwanted fracture. And so that's what I'm trying to avoid. If I can eliminate the midline resistance as soon as possible, then I know that now I can slow down everything. And then they're only going to be feeling the resistance of the sutures we don't want to break or we don't want to separate. It's a little bit easier to, understand and feel what's going on. I tell my patients this same thing so that they can understand it. So they're not just like, oh, I want to turn fast. I want to get done fast.
Yeah. That
it doesn't always. Yeah.
Wording that the other bones have to bend. Like I never pictured that's what's happening, but there's a pressure, like a torquing of all the other bones that have to kind of bend. That's an interesting way to visualize that. Right. What is the youngest age and the oldest ages that you've done MARPE on?
So I think my oldest is a 72-year-old female. Airway was part of it with her, but honestly, she had had a narrow smile her whole life, and she had a bunch of recession because her teeth were tipped out, and she wanted to correct it and have a more broad smile. So we worked with the periodontist on that case. He did some grafting and some SFOT. She's getting to the end part of her treatment now. She's doing really, really well. Got a great split, custom MARPE. That's the oldest patient I've done. The youngest patient I've done is actually 8, and they're in treatment right now as well. And this is a craniofacial patient. So this was a patient whose skeletal cranial sutures they fused early essentially. And so they had to go in and the surgeons had to actually, physically cut the sutures, expand the bones and correct the skull. But because the skull bones weren't fusing correctly, the maxilla was very, very, very underdeveloped. Yes. So we needed solid skeletal. We needed pure orthopedic expansion. Like we couldn't afford any dental tipping or any dentoalveolar bending. We needed this top jaw to become wider, and we needed it to come forward. We're still in treatment. We're doing a protraction face mask along with an MSE to widen the upper jaw. Because I didn't know. I worked with the team. I'm like, well, there's no reason I can think that we shouldn't do this. Looking up the condition that she had, it doesn't affect the maxillary sutures. It only affects the cranial sutures. And so there was no reason why it wouldn't work. But, I was obviously hesitant. So we took some progress CBCT images and you could actually see, the bones moving apart. That was very encouraging. What I will tell you is that the protraction side of things has been way, way, way slower than I would have anticipated. And my guess is that has something to do with that fusion of the skeletal sutures, because, when you're protracting, you literally are protracting all of the bones in the face, and all of the bones in the face are connected to the skull, right? So if the skull is not responding the way that it normally would, it would make sense that protraction would be more difficult. So she's progressing, which I'm super excited about. When I get the case done, I'll likely publish it so that, more people can be involved. But I do think that, skeletal anchorage in these craniofacial patients will be something that is a real game changer in the way that they're treated, because even before MARPEs, they've always done, crazy skeletal things on syndrome patients in order to get the results they needed, cutting the jaw in half using distractors. This is just a relatively simple way to possibly get some really big bone changes that we used to have to do really, really aggressive things to do.
What
So
a
we'll
great
see.
way. Yeah, what a great way to handle that
Yeah.
case. And I assume you didn't have to do a piezotome because
No.
you have a fusion of the maxillary. Her cranial
Correct.
stenosis did not affect the maxillary suture.
Correct.
Really interesting. Definitely share that case when you finish. That would be really interesting if you publish that.
Well,
Question about deviated septum. So I know that Audrey Yoon is doing research, and her research is showing that the septum doesn't straighten out. That's nothing I was ever taught, that it straightens out. Dr. Ting had taught me, and maybe other people, that you're just making it less of a problem because you're widening the nasal floor and the nasal volume, but the septum doesn't straighten out. So if you have a patient who needs a septoplasty, do you have them wait until after your expansion to do a septoplasty, or are there any negatives about doing a septoplasty or rhinoplasty before MARPE?
Yeah. I'm always careful to opine on things that are not directly in my wheelhouse, if that makes sense. You know what I mean? So I'm not an ENT, so I don't do septoplasties, I don't do rhinoplasties, but I'll let you know the way that I think about it and the way that I explain it to the patients. So most of the time when patients are seeking out a septoplasty or a rhinoplasty, they're seeking it out to improve nasal breathing, right? So the way that I think about it is, yes, septoplasty, rhinoplasty, both of those are ways that can potentially, when done correctly, improve nasal breathing and decrease nasal resistance, right? But if they're in a situation where they have, orthodontic and or, aesthetic changes, if they want to do an expander for other reasons anyway, then my thinking is, well, if you want all of these other benefits and you want to do the expander anyway, why would you put yourself through surgery if this may fix the problem? So I'm never going to tell them this is going to fix your problem. I'm going to say it's up to you. You can go get the surgery and then we can do this. And, maybe both will help. I talk about tonsils and adenoids the same way. Should I get the tonsils and adenoids out right now? Well, how big of a problem are they causing? That's an immediate way to make the box bigger. There's a lot of research on that, but I would say more adenoids than tonsils. If it's not a big resistance, it's not totally blocked or almost totally blocked, I always give them the option. I'm your kid's mouth breathing, they're probably going to be able to nasal breathe. If you get the expansion and you have the nasal passageways wider, they're probably going to be able to nasal breathe more. There's a good body of evidence that suggests if you nasal breathe full time, the tonsils and adenoids will shrink faster. And so it's up to you. And I have a fair number of patients that the level of their sleep disorder breathing is so severe that they want to go get the tonsils and adenoids out, before. And there are some that I'm if it were my kid, that's what I would do, because these things are huge, literally blocking off 100% of the posterior airway. The adenoids are huge. And I'm well, yeah, they might shrink over time, but a lot of time, and if it's my kid, I'd probably just go get them out. So that's how I approach it with them. In my mind, I always try to go to the least invasive option first, the least risky option first, right? So with the MARPE, you're not sedating them, you're not putting them under. So the risks associated with traditional surgeries where you do have to be sedated or put under are inherently lower. Right. So I'm always going to start with the lowest risk possible and then work our way up depending on the needs of the patient.
What if a patient already had a septoplasty? Are there any problems with then having a MARPE after?
From septoplasty specifically, I'm not aware of any. If something was crazy weird about the surgery or there was some perforation of the nasal septum that was, close to the inferior border, yeah, I would be really careful. And so we always try to seek out clearance from patients who have had prior nose surgery just to get an understanding of what was done and if the ENT feels that there's anything that we should be aware of or any reason that we shouldn't attempt this. Most of the time, we're educating ENTs on what this even is. So we have to explain, hey, this is what we're doing, expander, we're doing a cut down the middle. This, it's going to be widening, and they'll let us know, is this something that they're worried about? To date, I haven't had a patient that we got clearance on where the ENT was no, don't do that. So most nasal surgeries, I would say, are not a contraindication for MARPE expansion. But again, I'm not an ENT, so I haven't seen every nasal surgery possible and what there is. So we continue to seek their guidance before, jumping in with patients who have had a history of that.
Okay, that's really good to know. It's not sort of black and white, you had a septoplasty, you should not get a MARPE, or vice versa. So that's great. Okay, so before I get into some other really good questions, and we won't be too much longer, but I have a couple quotes from your course that I thought were great. So in one of the parts of your course, you show a patient with a jaw size discrepancy, so very narrow maxilla. And you mention how orthodontists are good at getting teeth to fit together, but you say something about, but should they really try to get the teeth to fit together with such a jaw size discrepancy? So specifically what you said is, Can we get the teeth to fit together with a 9 millimeter jaw size discrepancy? I would argue most of us can. As orthodontists, we're really good at getting teeth to fit in the absence of ideal sized jaws. But the more important question is, should you get the teeth to fit together with this large of a jaw size discrepancy? And I would argue that in most cases, the answer is going to be no. We should look at the root cause and we should idealize the anatomy as much as possible to set these patients up for the most ideal result, both dentally and health-wise, for the rest of their lives. And I just love that, because when you think of maybe an orthodontist who's not thinking of the airway and the breathing, but just aligning teeth, then yeah, they could bend and tip teeth for things to fit together well. But should we really be doing that when there is a narrow palate? And even without a dental crossbite, if that maxillary arch is not wide enough for the mandible, then it would be good to attend to that versus just straightening teeth.
Absolutely. And honestly, so one of the challenges I know that, many of you face is finding orthodontists who are willing to do this kind of treatment and to learn about this, even to step out and take a CE course or dig deeper into what's going on here. I mean, there are so many great practitioners who understand and know what's going on, but either they don't treat it or they don't want to treat it, and they don't have anybody else who will. So it puts them in a really tough spot. As it relates to talking to your normal, quote unquote, everyday orthodontist who's had traditional training, I think one of the best places to start would be with the literature about long-term dental bite TMJ type problems, because that's been established in our literature for a long, long time. The amount of compensation or tipping of the teeth that you have to do to get them to fit together, there is a very significant and definitive correlation between their chances of having TMJ problems down the road, their chances of having fracturing of teeth, even just dentition wear down. If the teeth have to compensate in order to fit together, they are more likely to have problems later. And a lot of that research we present in the course, and we provide you with the articles so that you can have a place to start talking and having this conversation. And, hopefully if that opens up a door, they say, okay, well, this kind of makes sense. Well, maybe then they start looking into some of the newer research that talks about how having this anatomy right really does decrease the long-term risks of kids either having or developing sleep disorder breathing problems. And these are the areas that we don't have 30 years of solid research to say that this is happening, but we have a growing number of studies that indicates that 30 years from now, we will. And so getting them on board with being a little bit more progressive, if it makes sense to them and they understand it and they can reconcile it back to the existing research than they have, then, there's a lot less reasons that they would choose not to do it.
So for orthodontists who might not be interested in learning about adult expansion or MARPE, is that maybe the best approach is to kind of share with them articles on the TMJ problem aspect?
The more you can speak their language and the more educated you are, the better conversation you're going to be able to have. Because if you go to somebody and you start talking about this E-line, and I'm not saying, I'm not knocking on any of the ways that people measure things, but if you start talking about the E-line or you start showing them two profile photos without, x-rays and it's just, that's not a result of the data that we have, right? But the intent with this course, in addition to, teaching orthodontists and dentists who want to do these procedures, is to provide everyone with the language that they will need and the background that they will need to have an intelligent conversation with their orthodontist, with their paradigm, whoever they want to work with in their area. They can now speak the same language. And when the orthodontist says something like, oh, expanders, I just do braces and I get the same type of expansion. You can ask the question, well, is the type of expansion you're getting more orthopedic or more dentoalveolar bending or more dental tipping? What kind of expansion are you seeing? And so, it's just it's a conversation that needs to have. There are some out there, unfortunately. I mean, they've been doing things the same way. They don't even have a cone beam. They're not even interested in getting a cone beam. You know what I mean? They've just, they've been straightening teeth for so long. That's what they're going to do. That's probably not your best bet as far as seeking somebody out. If somebody has a cone beam, that's a great first start, because at least they're seeing things and they have the ability, when you say something or when you put a bug in their ear, they have the ability to go back and look at some patients and say oh, that's true. I had a conversation with an orthodontist in Texas, and it was funny because my niece lives in Texas and they went to see this orthodontist, and the orthodontist sent me the plan that they wanted to do, which involved, braces to kind of make room for some impacted canines that were coming in. And so I sent him a video and I said, hey, thank you so much for seeing her. Thank you for getting all this imaging. I really, really appreciate it. And I was like, I'm kind of an expandodontist, so, take it with a grain of salt, but here's what I look at, you know what I mean? Here's what the bones look like. So, I was thinking maybe if we did a bonded maxillary palatal expander and we got that jaw wider, that it might create, and I'm showing it before and afters. And it was funny because I didn't really know how he took it at the time, But a year later, I saw him at a meeting and he's like, you know that video you sent me? He's like, you have me rethinking my entire practice, like my entire practice, you know what I mean? Because he'd been doing things for so long. And it's just, again, it's not that he was resistant to it. It's just that he didn't know. Like no one had ever presented it to him in that way. And so that's what I believe will happen. And that's 100% the reason why I created this course, was to have more conversations like this happen across all of our fields and specialties. Because if we start, seeing the same things and understanding the same language, well, now there is so much knowledge out there that currently isn't being used because they're not involved in this and they don't know about it. But as they learn about it, man, we will bring in so many great minds to help move this forward. And that's honestly what I'm most excited about.
Yeah. And that's funny how you had to tread kind of lightly talking to the orthodontist as well.
Oh, yeah. I mean, I don't want to call it bad orthodontist. I mean, like I say, I respect these guys. I respect the vast majority of my colleagues. I have a high, level of respect for. And so, I don't want them to feel like, I think I'm better. I'm doing something, better. I just want them to understand where I'm coming from and why I think the way that I do.
Yeah. And that was successful because he opened his eyes and you changed his life and many other people's lives because he was interested in listening and hearing. What about as myofunctional therapists? We might get patients who are referred, maybe not referred by their orthodontist. Maybe they're referred to us, they find us on Google or whatever it is. And the technique their orthodontist is using is retractive, maybe extractive, and not an expanding type of approach. Or how do you suggest we handle that from one orthodontist to another? How would we handle that with their current orthodontist?
Well, all I can say is this isn't a conversation I've had because unfortunately the collaboration between orthodontists, in cases where they're transferring or switching is not high. I have had a couple of times, but I would want, the respect of at least understanding where they're coming from. So in my opinion, the first thing I would do is go to the orthodontist and just address the concerns. Just be like, hey, this is what I'm seeing, help me understand the goals for your case and what you're trying to accomplish. And then just explain, this is what I'm seeing. If you have a cone beam, great. Do the cross section, measure it out. When I measure out that kind of how wide the bones are, I'm noticing that the top jaw is 3 or 4 millimeters more narrow. And I'm wondering, with everything I'm seeing on the myofunctional side, this kid is having a really hard time getting their tongue to the roof of the mouth. They're having a really hard time, nasal breathing, swallowing, all these kind of things. I'm thinking if this jaw were wider, that would really, really help me accomplish the goals of the myofunctional goals that we have for this patient. And so what ideas do you have about how we might be able to do that? So I would start there. If they're just completely resistant and they don't want to hear anything, then, I feel like at the end of the day, I need to be honest with my patient. So I'm going to work as hard as I can, not to throw the other guy under the bus. I'm just going to say, hey, look, we had a conversation. This is what we talked about. This is how they view things as far as I understand it. And we just kind of view things a little bit differently. And he's a great orthodontist. He's been around for a long time, does a lot of great work. I've seen a lot of great smiles. But, these are my concerns. And, if you want to look into that a little bit further, maybe you can talk to this person who kind of sees it a little bit differently. That's kind of how I would do that. I've had conversations with orthodontists just about TAD cases. I had a patient come in. Subsequently, they did have an MSE, but severe maxillary cant. So the maxilla was really, really slanted and it was narrow. And so I was a second opinion to a well-respected orthodontist in my community. And so I just reached out to him directly and I said, hey, when I saw this patient, second opinion, they live close to you, they love you. I'm not telling him to come here, but this is where I'm coming from and what I explained. And I was like, I'm happy to send him back. If you think that that's the right treatment plan or you think that might be better, you can do it. And eventually he's like, I don't really do TADs. I really appreciate you reaching out. Why don't you just treat them and let me know how it goes. Yeah. And I think that most of us, that would speak for how most of us would deal with something like that. Yeah. If I had a patient, I had a patient come to my office that wanted to know about the ease procedure, right? Dr. Casey Lee, the ease, are you familiar with that?
Yep.
Yeah. So they wanted to know about the ease procedure. And I'm like, okay, well, I don't do the ease procedure, right? I know a little bit about it. I said, I actually respect Dr. Lee a lot. I have looked into the data that he's presented and he does get true orthopedic expansion. I don't really know how he does it. He's not an orthodontist, so you're still going to need an orthodontist to get your teeth straightened afterwards. But I'm like, yeah, if you want to go see Dr. Lee, go see him, see what he's doing. This is what we do. This is how we do it. He can find out how he does it. And he went and saw Dr. Lee and he chose to get the ease procedure. So, he's going to be having it soon. I'm actually really, really excited because I have initial imaging on this person and now they're going to go get the ease procedure. And now I can take some imaging afterwards. And so then I'll at least have firsthand 100% complete images because, at this point, not that I have any reason to suspect that Dr. Lee doesn't present his data. Honestly, I think he does. But now I'll have my own view of it, right? I can look at it in any section I want, any detail. I'm going to be able to see exactly the type of expansion that's achieved, where it's achieved. And
Let us know. I had one patient who got the ease procedure from Dr. Lee a while ago as well. So what about if so my last question was if it's not, the patient's not referred by an orthodontist and the orthodontist might be using retractive techniques or not expanding. What if the orthodontist refers a patient to us and it's the same situation where now we can't really tell them to get a second opinion, or can we? Or just
So, I mean, here's the thing. So I lose sleep over this is why I lose sleep over, right? Like I lose sleep over people not getting the best care, or at least what I believe is the best care. Like I say, nobody knows what the best care is, right? We all have our opinions based on the current knowledge, but I am where I am. So this is me. So it's like at this moment in time, I want all of my patients to receive the best care. So for me, it's more important for them to receive the best care, or at a bare minimum, not to receive what I would think of as bad care, right? So if ever there's a patient who I feel like in my mind, right or wrong, maybe it's bad, maybe it's not, but in my mind, it's not good care, just because of probably a lack of education, right? I'm not going to do that. I'm going to tell them, I'm going to give them a second opinion. I'll just call and tell them I did it. I'll just be like, hey, I know you sent me this patient. And here's the thing, it's just I just really felt like in this specific scenario, this practitioner would be best for them. A lot of times this will happen with TMJ. I've had people, come over from TMJ and, it's somebody who manages TMJ, but then they're trying to send them to me. They're not having good luck. And I'll send them off to another TMJ specialist because I feel like that's where they're going to get the best care. And I'll just let them know. I said, hey, with this case, this is what I did. And I think, if we're open and honest about it, will I lose that referral source? Maybe. If I do, though, I mean, honestly, it's one referral source. If my whole career and practice is going to be ruined by one referral source, I've done something wrong. You know what I mean? I made a mistake that's much bigger than I should have. But yeah, I don't know of any referrals that I have lost doing that. I mean, maybe I have, but I don't know. And if I did, though, like I say, my sleep is worth more than one referral source.
Yeah. And it's great hearing from you as an orthodontist, how you handle these things and how we should with other orthodontists. And what I tend to do is really, like what you said, I speak of it from the myofunctional perspective, be really great if we had more tongue space and, all those types of concerns, but put it in terms of tongue space and nose breathing. So to help us accomplish our goals. And so I kind of put it in that wording. And I've had many cases where I've had to tell the parents, look, this is my opinion. This is where we're coming from. This is what I see. Your orthodontist might not agree with this. So if you did want to ask for other opinions, you're welcome to do what you want, but this is just where I see it. So kind of, careful with your wording, because I've spoken with orthodontists who might not see the same perspective or might say, oh, there's no such thing as a skeletal crossbite. The patient's on crossbite. They don't need expansion. And I'm like, right. Patient has sleep apnea, so it's I actually did have a case and the parents went to a different orthodontist and who recommended expansion. And this kid's life is totally different than, We've
all seen it. Like I say, you can't unsee it.
Right.
Unsee.
So exactly. And we all care so much that, we lose sleep when we feel like a patient might not be getting a treatment that we might think could benefit them. Okay. So last thing, first of all, to sum this up, you're amazing. Your course is awesome. This is so good. We've covered so much today. I just really appreciate hearing from you as an orthodontist who has such an airway minded focus and you see the big picture. And you can, in the very end, after my last question, you can let everybody know how to access your course as well. But I did see a post on Facebook that, Dr. Ting posted it. And maybe you did as well. Also in the MSC group, it was you, Rebecca Backow, Audrey Yoon, Ilya Lipkin, Richard Ting, Mariana Evans. And they said something exciting news is coming up with all of you. Can you talk on that? Or is it top secret?
I wouldn't call it top secret as much as I would call it unfinalized.
So you can just say top secret. It sounds way better. No.
Yeah, right. Yeah. So here's the deal. I mean, basically, I approached them because exactly the same thing we started talking about. Why did I create this course in the first place? This is going to be, the more people that we can get collaborating on getting education out there, the better. So those individuals that you listed were the ones that I have the absolute highest regard for in this space. And I feel like have been contributing so much for so long. And so I asked them to get together in order to see if we could collaborate on a project. And the goals are the same, that we've talked about. The goals are to get quality education out there, but also with a support component, meaning being able to have, especially newer practitioners, have ongoing support, but not only even just, ongoing from, the 5 or 6 of us or whoever it may be, but continuing to have, systems to be able to bring more people in so that, as you're the mentee, but then you progress and become the mentor. So again, all of the details are not worked out yet, but, if it all works out, I would be honored, truly honored to be able to work with them on a project to help make MARPE education better, more accessible, and more self-sustaining going forward. So that's what we're working on, but we'll hold off on any of the final details until we actually have them. So we're still collaborating, we're still talking. We just haven't worked it all out yet quite.
Let us know what you decide and how, what it's going to be when that time is ready, because that sounds so great. And what's so great about all of you people and everybody in the airway field is that everybody is here to help, and it's not competitive, but everybody is teaming up to help our patients get the best care possible and to get patients who are unidentified get identified and get treatment. So it's just such a great unity. So I know we were here for a long time. I wanted to thank you so much for all of your time, your support, your enthusiasm, your education. What's the best way for someone to find access to your course?
So the course, we'll go ahead and just put a direct link in the description. I'll send that over to you. That's the easiest way because it's a new course. It's not indexed on Google. So if you search MARPE 360 or MARPE Manuele, you're probably going to find a lot of articles, but not the course. If you are searching it, what I found by mistake actually is if you go on the DuckDuckGo search browser. So if you go to DuckDuckGo, which is kind of like a Google, but different, and you type in MARPE 360, it's the first thing that pops up. But for some reason on Google, if you type in MARPE 360, you got to go 4 or 5 pages to find it. So if you're searching it, just go on to DuckDuckGo, search MARPE 360, and we'll provide a direct link in the description so that, you can get to it there.
Okay, great. Is there anything final words you want to say before we close?
Only thank you for all that you're doing. I mean, it's so awesome that we have a platform now to reach like-minded individuals and to provide resources and support like we never have been able to. I mean, the podcast, the YouTube, online, lectures, all that kind of stuff is just so awesome. And I know that, you could be spending your time doing a lot more things that would probably be a lot more, financially to your benefit in your practice and whatnot. But the fact that you commit yourself to furthering this cause and creating this collaboration is awesome. It's truly inspiring. So thank you for all that you do. And thanks for having me on today.
Oh, thank you so much. And same to you. Thank you for all of your time. And we look forward to talking to you again at some point in the future.
Awesome.
Thank you.
Thank you for listening to our radio style broadcast, where we bring different perspectives to the airway world in an easily digestible format. Different hosts, different views, same airway talk. Don't forget to leave us a review. Bye-bye.